you see my screen?
Yes, I can see your
So,
screen very well.
perfect. So we just talked about the metrics. Now let's put the picture together. What do we do to optimize our radiation output? So we talked about this, and I think I showed this slide last week. Fluoroscopy comes in all different geometries and shapes and sizes. There are principles that are consistent for all of these machines. But for the most part, one of the most important things that affects radiation output is how we use the machine. So keep that in the back of your mind as we go forward. The radiation dose to the patient and ultimately the exposure you get as a physician in the room or a technologist or physicist all depends on the way we use this machine. And then as a quick reminder, when we were optimizing imaging quality last week. Now we're going to try to optimize patient exposure. There are a lot of variables. There's probably something like 50 variables around this. And it's really hard because if you change something over here, it has a downstream effect that may change image quality over here. So we'll just kind of keep that in the back of our minds as we start talking about the things that we're going to try to do to optimize. All right, so first thing I said, the most important thing for dose optimization is determine how we use the machine. So the other techniques that influence patient dose are going to be total time. Obviously, if you want to reduce the amount of dose you give to the patient, reduce how much you're stepping on the pedal, how much time you're actually exposing them. The geometry, which we've talked about today, the pulse rate, which we talked about last week, and filtration. Excuse me. So let's talk about total time. This is a no-brainer, right? The less your foot is on the pedal, the less radiation the patient's getting. So what we're going to want to do is we're going to try to do intermittent exposures. We're going to want to use as much as possible the last image hold or the last fluoro hold so you can plan your next step. We're going to try to do as much of our imaging using pulse mode. Now, we did talk about the fact that there really isn't continuous mode anymore. Continuous mode of 20, 30 years ago is 30 pulses per second today. So it's actually the highest usually you go is 30 pulses. Some older systems can still go up to 60 pulses per second. Those were more typical in cardiac systems. But what we want when I say pulse mode is we're typically going to try to do as low a pulse mode as possible that gives you the image quality you need to do the temporal resolution to do what you need to do as a physician. All right, so geometry. We talked a lot about this idea of the isocenter and the international reference point, that being the point where we do all of our dose calculations. There's another point that's very important. You see this little X right here. So here's isocenter, and here's this point. It's called the compliance point, or if you're in the US, it's called the FDA point. It's 30 centimeters from the detector. It's always fixed 30 centimeters from the detector. And this is the point where the system is trying to match the dose. So if this point right here, this X, is aligned with our international reference point right here, well, then the dose, so if it's right here, then the dose that you see on the screen is going to represent the dose that's going into the patient, so the skin dose. Now, if you take and you move your imaging, your II or your flat panel, and you move it away from the patient, what you do is you've moved that compliance point, that dose point, up. Now, this point down here, the skin dose is getting more dose because the system is trying to make the radiation output to this point. And so you've shifted it from here. So let's say it was a good dose here. Now the dose is supposed to be quote unquote good right here. Therefore, everything below it is getting higher dose. This obviously only accounts for the fact that in some systems, mostly interventional systems, the II or the flat panel detector is variable. It can move up and down. And this up and down point can really drastically affect how much radiation is coming out of your system. In the United States, we have a point, 87 milligray that we have a dose threshold, 87.5 milligray per minute or 10 R per minute. The systems, that is supposed to be its maximum output dose at that point that we were talking about, that dose compliance point. The dirty secret is that is true. I can go in and I can use all my blocks of plastic I've been talking about to mimic all my different sized patients. In fact, I can actually go put lead into my beam. So I got my, if I have my II or my flat panel right next to my patient where it's supposed to be, where my phantom, whatever I got here, and I put all the time, everything I can possibly think of, lead and everything. So I make the system use all of the radiation it possibly can to penetrate all of my phantom. If this ion chamber, if the, excuse me, the II is at its proper location, the dose should not exceed my threshold. Now, if I move it up, it will exceed that threshold. You can see how it goes from 87 all the way up to 140 in this one particular machine. So what I'm trying to say here is on these variable II or flat panel systems, on these C-arms, you do want to keep the geometry where the detector is as close to the patient as possible. We talked about how that is the best image quality last week. In this environment right here, you'll have good contrast to noise ratio, less scatter, less noise. You'll also have less of a geometric blur due to the magnification effect. So this will give you the best resolution and contrast. That's great. It will also give the best dose to the patient, and it'll give the lowest dose to the operator because there's just less scatter coming off the patient into your face. If you have the II high, then obviously lower image quality, lower spatial resolution, higher dose to the patient, and potentially higher dose to you. Now, I recognize the fact that there are times where the detector has to be up a little bit because you may need to get your hands in there. I recognize that sometimes it just has to be where it has to be. But in the best case scenario, you should keep it as close to the patient as possible. Now, we talked a little bit about having the patient as far away from the x-ray tube as possible. This obviously depends a lot on how high you can use the table, how high you can set the table, and the operator can use it comfortably. If you have a short operator, the table is going to be lower, and therefore the patient is going to be closer to the x-ray tube. That's just something that you have to deal with. In a best case scenario, push it as far away as you can, and it just reduces the dose to the patient. In some situations, you can actually manipulate where the x-ray tube is. So on these tilt tables, one vendor that I know of, maybe other vendors can do this, but one vendor can actually, there's a button you can push on it and it will make the x-ray tube go farther away. It goes from its normal position to down a little farther. If you do this, and this is how we use our machine at our center, because this is actually a picture at my hospital, it immediately reduces the dose of the patient by 15%, just because it extended the distance. Now, they built this here actually to make it a larger field of view. So if you had a big patient, the only reason they did that is so that you could actually image a little bit more anatomy. What they didn't realize was we would use it, as most people use it now, for dose reduction. So know your system is what I'm trying to say here. Know that, make sure you understand all of the buttons on your machine. Make sure you understand all of the operating geometries, because there may be some geometries that are better than others, and you want to make those the defaults. And so ask your system vendor to make sure you're trained on all of the quote unquote bells and whistles, as we say here in the US. You want to minimize how the different angles where you're passing through a large portion of your body, the patient's body. So you want to minimize lateral projections and oblique projections when you have a rotating C-arm. The reason for this is obviously because if the machine sees there's more attenuation or more tissue between the tube and the detector, well, that means that the machine's going to have to turn up the radiation output. So therefore, the skin's going to get more dose. It's a simple. So we're thicker this way, it needs more radiation. We're the thinnest, typically anterior to posterior. So as we keep the beam more aligned along the thin geometry of our body, then we're just safer. It's safer for the patient. The next is, if you can, and we talked a little bit about this for peak skin dose, don't do everything in one skin port. If you can, move the patient. Maybe you shift the table a little bit superior inferior. Maybe you shift it laterally. Maybe you can actually move the x-ray beam. If you have a C-arm, you can actually move it. You can rotate it a little bit if you absolutely need to. But breaking it up, where, for example, you have a 30-minute procedure that gives you 1,500 milligray in one location, the same could be true 15 minutes, 10, and 5. And I know this is an exaggeration, but you move that patch around. Now there's no one max skin dose that's that high. So spreading it out. If you're doing angulations, make sure there are no points of overlap. So if you angle one direction and you think, oh, I'll save my patient some dose by angling a different direction, well, that's true for part of the body up here, but this point right here overlaps. And that dose hot spot, you may not think about that, can add up very quickly. So be very conscious if you are angling that you don't have these overlaps. Now, I have to admit this is not that easy, especially if the patient's draped in sterile cloth and so is the tubes. A lot of the, not a lot, some of the newer interventional systems, because they know the table location and they know the tube position, it will warn you if there is a hot spot, if there's an overlap. So as you're going along, you're seeing the dose map on the screen in real time. And if you angle, it'll immediately say, it'll warn you saying there is an overlap. You might be aware of it, or you may elect to move forward even though you know that there's an overlap. But at least some of the newest systems are becoming smarter and they're warning you. Okay, on these tilt tables and to a lesser degree some of the interventional systems, well, I guess I just say in general, these table pad, when we put table pads, we put patients on the pad, they're meant for comfort, right? But the pads absorb radiation. So if they absorb radiation, the system needs to put more radiation out to get the same dose to the detector. So if you have a tube up here and the detector down here, and you have a pad and a patient on here, if you put the pad here, this machine thinks this patient's thicker, so it will irradiate more. Okay, on this situation, this geometry, if you have a pad and a patient, the system still says, oh, hey, I need more radiation to get through, but the pad is between the patient and the x-ray tube. So the pad actually absorbs it. So in this geometry, if the tube is below the patient, you can use a pad. That's okay. It doesn't affect the patient dose. It actually helps it a little bit. If the tube is on the opposite side, so tube, patient, pad, then that will cause an increase in dose to the patient. And this is typically why in normal radiography, CRDR, we don't use table pads. They all climb on those horribly hard surfaces. The whole reason for that is because those hard surfaces do not attenuate that much radiation. And so putting pads and pillows and blankets and putting our patients on that actually increases the dose to our patient. So just be conscientious of where your tube is to your pad. Now, not all pads are created equally. There are some pads out there, and they tend to be the inexpensive, so the cheaper versions, things that you can buy from third parties, vendors. They tend to be made of really attenuating material, lots of gel, lots of foam. And so these can actually attenuate the beam by 60%. I've seen them upwards of 60%. That means the machine has to put that much more radiation through your patient to create the same quality of image. So A, it can affect image quality, but B, depending on if it's an overtube, that can really increase the dose of your patient quickly. Usually the pads sold by the manufacturers tend to be the lowest attenuating pads available. It's just because they've been created or engineered for fluoroscopic procedures. The worst pads out there, and this is something we can't really control. But the worst pads out there are usually the comfort pads that are in the actual patient beds. So if you're doing a C arm in the maybe the ER, or if they're up on the floor and you take a portable C arm in to do a procedure or whatever, and they're in just a standard hospital bed, those pads can actually attenuate quite a bit of radiation. And one of the things that, as a medical physicist, I like to do, for example, we've just added a small part to our, we added a building to our hospital. So we've increased the number of beds we have in our hospital. And the hospital went out and bought all these beds and all the new hospital beds and all these pads. And they, of course, they're looking at the most comfortable pads, the pads that hopefully reduce all of the bed sores and all of these things. They didn't think one little bit about radiation. And so when we found out what they bought, we did some measurements and I showed them that they've, in effect, increased the dose to all of our patients by 30 to 40% if we have to image using those pads. So just be careful of what pad you put, especially on the fluoro tables. You can control that in radiology, and work with your hospital counterparts as much as possible to help educate them so they make the correct decisions, especially in places like the ER where you do a lot of imaging. And it goes without saying, I know you all know this, but the dose that the patient gets, it directly affects the dose that you get in the room. Because as we know, the radiation goes into the body and it scatters off the body, and the radiation that goes into the body will scatter out of the body. And so the radiation that we are being exposed to, unless you're actually sticking your hand into the beam, the vast majority of the radiation we're exposed to in the room is from scatter. So if you're using a high dose, uh, and therefore you're getting a lot more scatter out. If you're using a bad geometry, it's going to adversely affect the image and the patient, but it will also affect you. So just think of it as a 2-for-1. The better you are for lowering the dose of the patient, the better you are from reducing the dose to yourself as a staff member. Okay, so let's move on. So that's geometry. Let's talk pulse rates. So establishing the appropriate pulse rate in fluoroscopy is actually very important. It helps when we set up the procedures and the exam protocols from the beginning. It helps the physician when they walk into the room, they don't have to think, okay, this button does this button does this button. They can go in and they work, and their focus is on the patient. And if they're actually operating the machine like they typically do in radiology, then they know, oh, okay, I need a little more radiation. I just push the next button up, or I push the button above that. If you make it sensible, then it takes a lot of stress out of the process for the radiologist or the physician to operate the machine. So what we do is we need to set up anatomical programs. As the technologists know, when you load the patient on the system, well, what you're going to do now is you're going to tell the system what you're going to do. Is it a VCUG? Is it a video swallow? Is it a barium enema? Or if it's some kind of interventional type procedure, whatever it is, an embolism, whatever your procedure you've built, you have an anatomical program that you've established. And you need to set up some presets to it. You need to build into the background all the right values so that when you select it, it's correct for the right size patient. And so we need to make sure the pulse rates make sense for what we're doing in that, video swallow. We're going to have a higher pulse rate. If we're doing a line placement, a PIC line or something, we don't need a lot of pulse rate. We can do a 2, we can even do a pulse rates down to 3 pulses per second or 1 pulse per second. We need to set the system so it has the right kind of filtration. We talked about this last week, how all of the systems tend to want to use the highest filtration as possible. The higher the filtration, the lower the skin dose. That's the whole reason we use filtration in fluoroscopy. Well, 90% of the reason. The other 10% is to improve the image quality, to improve contrast. Too much filtration, however, can adversely affect contrast because your KV goes up. Higher KV means lower contrast in the body. And higher KV, higher filtration equals larger focal spots. That means your spatial resolution goes down. So there are trade-offs. If you're going to be imaging a little kid, maybe you're doing something in the heart, You don't want to use a lot of filtration because then you might not be able to have the resolution necessary to see the very small vasculature that you need to see. And then obviously you need to make sure that the system is set. So based on patient size, maybe the grid is already selected to be out versus grid in. We talked about the pros and cons of grids last week. Views, this basically means when you walk in, if you're going to be doing, say, a barium enema or whatever it is, you know that you're going to be doing maybe a fluoro, you're going to be doing maybe a couple of spot films. You have a procedure built, so a workflow built. So you want to make sure that workflow is built and it makes sense so that when you're stepping through it, going from the next procedure to the next, you collect all the information. So when you get back to the reading room, you can do your, if you're doing it in person, you can do it so you can read through and do your diagnostic, get your diagnostic. Or if you're in the reading room, when the procedure hits your work list, you know that all of the imaging coming across will be able to provide the information you need for to make your diagnosis. So, how many fluoro units should you have? Digital angiograph, digital images, cine runs, DSAs. You need to work all that out. So I talked a little bit about how you need to have the doses set as a function of size. So this is just an example of how we do it at my center. I'm not saying it's the right way or the wrong way, and you may differently do it a little bit different. Every system is going to have some way to adjust the machine so you can change the output to you can change the output of the machine. In this machine, it's a Philips unit. It has these uh, 7 settings, and they just arbitrarily label them newborn all the way up to extra large. And so what we did in our anatomical programs is we went in, so let's say it's a VCUG, and we have these 7 settings built into our VCUG. And they're based off of these basic sizes, basic patient thicknesses, anterior, posterior, lateral, whatever you want to choose as your metric. And so we set it up so that the dose to the detector goes from small to large. You need to make sure you keep the right dose to the detector as the patient gets bigger and bigger. Remember, the dose of the detector determines the noise in the image. And it also allows the system to pick the right KV and the MA and the right filter for the procedure. So if you don't have the right dose to the detector, then all of these settings aren't going to be right. The image quality won't look right. Contrast will be a little off, and you may be even noisier as you get to bigger patients. So we talked quite a bit about, and I showed you some examples of setting the right dose if you go when you change your pulse rates. And you may recall it's called the Afrique principle and the Keith Strauss rule. So we talked all about that last week. I won't go over that. You can go back to those notes. But setting the right dose to the detector is actually very critical, and setting a variable amount, because not every one of your patients are going to come in looking a certain way, especially if you're in a pediatric center where you will see everything from neonates all the way up to obese teenagers. And then pre-program those so it just works seamlessly when you walk in. You, the physician, walk in to use the machine. So we talk about using pulse rates. Pulse rates, the number one way to reduce dose in fluoroscopy is just not push on the pedal, right? So reducing the total amount of exposure. The second one is using these pulse rates. So here is just a little bit of math that I did. If you have 30 pulses per second as your relative 100% dose level, so everything less than 30 pulses per second is going to reduce the dose. If you go down to 20, you've reduced it to 67%. Obviously, you go from 30 to 15, you've halved the dose to the patient. And then you go down from 8, 4, 2, 1. You see how the doses are dropping. If you're able to do a procedure using 1 pulse per second, you're using only 3% of the dose compared to if you had done the same procedure with 30 pulses per second. So obviously reducing it as much as feasible allows your system to reduce the dose of the patients. It's just a quote unquote lower patient dose system. Now, what you want to do is you want to set it up so that for every one of your anatomical protocols and all your procedures, VCUGs, video swallows, all that, you will set the appropriate pulse per second when the system is turned on or the exam is loaded. And you have to do this based on the clinical needs and obviously uh, the comfort level of the radiologist. I can tell you in our center, we do all of our pick lines and all of our line placements at 1 pulse per second. That's just how it's always been done. And it's been largely championed by one radiologist. He, of course, is the section head of our Fluoro unit. Now, we've had other people come in and they've said to themselves and to us, 1 pulse per second it's too slow. Obviously, the image is 1 pulse per second. You're getting one image per second. So you have to adjust the way you think. You can't just go in and stick that tube and go right over into your patient because obviously you're moving faster than 1 frame per second. And so it does take a paradigm shift on how you operate the machine. If you're willing to do that, and if you have the comfort level, then you can probably pick most pulses per second depending on the type of procedure you're using. This is simply an example. Once again, this is how we do it at my center. I'm not saying this is the right way. I'm not saying this is the wrong way. What you see here is just a general list. So as I mentioned, our tubes, GJ tubes, we set up our procedure to have 3 options. So you load the GJ tube procedure. On the console, there will be 3 dose buttons. If you have a Philips unit, you know they're called Fluoro flavors, as an example. Siemens has different, they're all just labeled something different. But in my case, we have 3 dose values. And it's the red values are the default values. So in the GJ tube, it's defaulted at 1 pulse per second. So if the patient the radiologist goes in there and they're trying to place this GJ tube and they're just running into a little bit of problems, maybe they'll elect to go up to 2 pulses per second or even maybe 4 pulses per second. So all they have to do is push the next button up or the next button up. Now they have no choice. They can't go up to 8 or 20 or 15 because that's just not an option in that protocol. So there is a limitation. Other vendors, such as I can speak for Siemens, for example, you can go from as low as 0.5 pulses per second all the way up to 30. And so you just open up a different window on your little table side system and push a couple buttons and boom, you got the world is your oyster on this one. You can do all the pulses you want. But in most places, you're going to set it up so you really basically have 3 options. And the why and how you choose those 3 options really just depends on working with the radiologist. We use for our video swallows, ours is 20 as our default. But if they really wanted to, for whatever reason, they could go to 15 and 10. And you see all the other examples. The reality is, though, is if you set the pulse rate low initially, and the radiologist or the operator walks in and they start working with the machine and they think to themselves, I just can't quite see or do what I want. Well, they obviously have the option to go up. And they can, in our case, they have two more elevated dose options or pulse pull. But the opposite is rarely true. If you set the default at the highest value, you're rarely going to have an operator or a radiologist walk in and say, oh, this image quality is just way too horrible. It's too good. This is way too good, way too good. I want to reduce my dose. That rarely happens. So oftentimes we'll set it at the minimum, and then we give them 2 options or 3 options, whatever your system allows, to increase the pulse rate, or in other words, the dose to the patient. Now, when you do this, I have 2 examples down here. This is a machine that I worked with, and you can see that the 3 buttons on the machine would reasonably go from low, medium, high, which you see on the right graph. The irony is it actually went from low, high, medium. And every year, every time I would go into service and work on this machine, I would adjust it. And then I'd go back the next year and it was all mixed up again. Every time the service engineer would come in to do their PMs or their routine periodic maintenance, they would they would um, they would take away all of my corrections that I put in it, and they would reload the software. They would basically refresh the system. It drove me nuts because every year I'd go in, I would tell my radiologist, if you want to go higher dose, go 1, 2, 3, and they would go in and they would do that 1, 2, 3. Well, guess what? They always stopped at 2. They never needed to go to 3 because guess what? 2 was always the highest dose. So you want to make sure your settings, whatever you set, are logical so that the operator just knows what to expect as they're progressing low to high. So I mentioned filtration is, so we listed filtration as another optimization. And I've already kind of talked about this, but filtration almost always starts as the highest as it works down as you get towards bigger patients. It's pretty much always zero point 0.1 to zero point 0.9 millimeters copper in all of the various different systems out there. I already told you that too high high filtration can reduce KV, can reduce low spatial resolution. Excuse me. So you want to optimize this as much as possible. All right. Now let's talk a little bit about cone beam CT. So up to this point, we've really just largely talked about fluoroscopic systems. I would argue those four principles are pretty much the same. If it's an interventional system, if it's a tilt table, if it's a cone beam, excuse me, like a fixed C arm, like a mobile unit. Now let's talk cone beam. So I did a study end of last year, and I compared radiation doses from the cone beam CT, the spin that you can do in the fluoro system, a C arm, compared to an actual CT scanner where you normally do your biopsies. So you can see my friend here, this Phantom. It's got all my little MOSFETs in it. It's a male Phantom with a breast attachment on it, so it mimics both genders. And what I did is I looked at a couple of different protocols or procedures. And we looked at doing biopsies. We looked at doing various different, well, we looked at a variety of different reasons why we would do a cone beam CT of the thorax and the abdomen. And we did it for an adult Phantom, as I've just showed in the previous slide. And we also did it for a 5-year-old, just to kind of give us a range of the doses, small patient to a large patient. And I took these MOSFETs and I stuck them in all these organs. In the thorax, I did lung, breast, heart, and in the bone, I put it in the T-spine and the sternum. And from the bone, I got bone doses and red bone marrow. And then in the abdomen, I did just your major solid organs: liver, stomach, pancreas, spleen, gallbladder, kidneys, intestines, colon. And then once again for bone, I did the T-spine so I could get bone marrow. And what I did is I went in, which you did under fluoro if you're in the C arm, or if the CT system, you did a planning radiography or a scout. And I imaged the patient using 4 field of views. Max field of view, which is roughly 20 centimeters on my system, 12 and a half, 7 and a half, 2.5. And you can see I kept most of the MOSFETs kind of in that same image, but there are a lot of MOSFETs above and below that as I kept as I collimated down, down, and down, fewer of those of the MOSFETs are being exposed. So in theory, I was exposing less of the organs. And so the radiation dose should technically go down at each one of those. And I took those 4 field of views, those 4 different collimations, and I plotted the doses and I fit the values. I did a regression curve and a couple of things to point out. So I'll explain why I did the regression curves in a second. But first thing you can see here on the IR, so this is the C arm doing the CT or the cone beam CT, the 5-year-old abdomen chest and the adult chest basically were all of the same dose. But the abdomen, when you're doing the adult abdomen, the dose is much higher. It was an order of magnitude, almost 2 orders of magnitude higher. Not order of magnitude, a factor of 2. We went from 1 to a half to 2, give or take, 1 to almost 4. So a factor of 2, actually, I should say. And when you compare that to the actual CT itself, so doing just a normal helical CT of the chest or the abdomen, you can see that they were mostly the same, but a little bit lower than the cone beam CT from the C arm. So cone beam CT, for all intents and purposes, used to be higher dose, much higher dose, several years ago than taking the patient down to a normal CT and doing your biopsies there. That's mostly changed, at least on the system that I have that we tested. And I think it's true for most systems as we've looked at this. In other words, if you're still upstairs or wherever you're at in the interventional suite and you do a normal cone beam CT, obviously the image quality is going to be slightly different. We talked about that last week. But dose-wise, they're pretty equivalent. There are some cases where they may be a little higher, but they're mostly equivalent. Where they are different is the fluoro mode. So if you're on a interventional C-arm and you just step on the pedal and you're doing normal fluoroscopy, here you can see I fixed my ordinate axis, so they're the same. You can see that the fluoro dose is just nothing. It's right there on the 0 mark. It's actually higher than 0, don't get me wrong, but it's less than 10. It's less than 5. It's actually, I think, only 1. Whereas if you compare the dose in fluoro for CT biopsy, it's much, much higher. And that's just because obviously in fluoro, you're doing low real time, it's stationary, but in CT, you're taking and you're making about 1,000 or so images, even though it's a relatively low MA, so you can create a volume image. So what we did is I created these regression models and I combined them together so that I could create one empirical model. And what this allows me to do now is I can go in and I can pick however many cone beam spins that I'll do on my C-arm fluoro, which is shown here in orange. So let's say for a 5-year-old, I go in and I do 4 in whatever procedure I'm going to do. Let's say I do 4 C-arm spins. And then let's say I do, 10 seconds of fluoro. So that's all that my procedure's done. So my patient dose is going to be, 4 millisieverts. Now, on the CT side of that, if I did the same biopsy and I go in, I do my normal chest tomograph to localize it. I find whatever, let's say I'm doing a biopsy in the lungs. I find the place, the relative center for the location for my biopsy. I center it, and so then I switch my CT over to fluoro mode, and now I turn on and I do fluoro for 10 seconds. You can see how the dose from the CT is roughly 7 or 8 millisieverts. So you can see how in all of these cases, basically the dose from the fluoro mode of the CT scanner is the highest portion of it. That's why the blue line has that angle. The slope is much stronger than the orange line. There's basically no slope to orange because the fluoro dose or dose to fluoro coming from a C-arm is almost inconsequential. Now, if you come over here to that adult abdomen, you remember over here, this curve was much higher when I did the cone beam spin on my system, on my C-arm system. Let's say I did 3 or 4 cone beam spins plus 10 seconds of fluoro. In this case, the CT scanner in my conventional CT scanner, even though I'm doing 10 seconds of fluoro, which is a high value relative to a 5-year-old, to an adult, it's actually a lower value. And so this is kind of just the model I built so that I could tell so if the interventionalist came to me and says, hey, I want to do 5 spins and I'm probably going to do maybe 30 to 45 minutes of fluoro, just if for whatever reason they kind of had a clue of what they're going to do. I could basically tell them, all right, well, if you're a 5-year-old, then I would go do that I would do that on the interventional C-arm without a question. If I was doing that, if I was a large adult, a big adult, then I would say I'd go use your traditional CT scanner. Now, this is just an example of the actual, because I put the MOSFETs in all the organs. Here you can see the actual organ doses. Now, as you change your field of view, you can see that the dose, let's say here in the lungs, I go from a large 20 centimeter field of view down to about a 2.5 centimeter. As I cone down, you can see the dose to the organ drops drastically. And that is true for every organ I measured. Some organs, however, just didn't really change. The doses were already low to begin with. So this is where you see that the CT itself, when you do just the normal helical motion, the helical scan of say the chest or the abdomen pelvis, the CT itself is generally pretty low. And the reason behind that is because of the tube current modulation, which we talked about many weeks ago. When the C arm spins around the body, it does modulate. Every angle will be a different MA, but the difference is the field of view is this big versus on CT, it's teeny. It's only a couple millimeters wide. And so the CT scanner can modulate much, much better. That said, the doses are getting much better. They're much more equivalent today. So CT acquisitions on a C-arm fluoro units are higher dose on average than the traditional CT scanners. CT fluoro is a higher dose than C-arm fluoro. Obviously, you get more information though. And so that's one of the benefits of if you are going to do fluoro on a CT scanner, well, at least you have more information. You have 2D versus 3D information. Whereas as excuse me, as everyone knows, and forgive me, I don't know why my image is covering up my text. I'll fix that before I send it out to you guys. But obviously, you've all seen fluoro images. There's a lot of anatomical noise because it's a superposition of all the anatomy in one two-dimensional image. Whereas obviously in CT, we flip it on its head. So even though the traditional CT scanner, it will have a little bit more dose in the fluoro mode. You just get much more information. So typically you go faster. You're only working for a few seconds in CT fluoro mode, whereas you might be working for tens of minutes in a traditional C-arm fluoro mode. All right, so let's shift gears. So we just talked about dose optimization for traditional fluoroscopy, for cone beam, spin CT in the fluoro suite. Now let's just talk a little about dose diagnostic reference levels. So this is data that Dr. Panrutai gave me to look at. So this is your data. This is Thai data. You guys have made great strides with the first initial review of your various different locations, north, central, northeast, and south. So the kind of major areas in Thailand. You looked at about 14, just shy of 1,500 cases. That's wonderful. So what I did was I looked at your data and then I went out into the literature and I just so you guys have comparisons. I'm sure you did the same thing. This is not meant to say you're doing bad or you're doing good. This is just meant to give you a way to compare things. So the first question that I have, and this is something I would ask you to go back and consider, is your units listed here as milligray centimeter squared. I'm sure that's true. I'm sure you wrote them correct. But when you compare their units, gray centimeter squared, if I do the conversion here, so make these gray centimeter squared, when I look over here, let's say 242 milligray, that would be 0.2 gray centimeter squared. So that would put you guys down here at the near zero. So I think there's a discrepancy in the units. So that's one thing I would just consider looking back and making sure that's not milligray meter squared or grays centimeter squared. Assuming these were the same units, then if you just do quick comparison here, you guys got right here in the 3D mode 242, and the average is less than 400, but 242 puts you basically at Korea, about the equivalent to Korea. You're lower dose than US, so you beat us. Lower dose than Spain, both their measurements in 2008 and 2016. It's equivalent to, or maybe a little lower than Germany, and much lower than Switzerland. Everyone's doing better in Switzerland. So anyway, here's just a couple, aneurysms. This is, in my summary, I'll explain a little bit more about this, but you guys say embolization, They talk about aneurysm coil embolization. It's it's difficult to know exactly what everything is. Let me actually here I'll come back. I'm going to show you data from a variety of different countries, and what the procedures that they chose to use to calculate DRLs, you're going to see is different from country to country to country, which is fine. Every country should pick their main procedures and collect the DRLs for that because that makes the most sense for their country. But when you go to pick those procedures to collect the data, you need to be as specific as possible because if you say embolization or aneurysm, there are a lot of different types of procedures that may encompass that. And so for example, here in your neuro, you guys list embolization of intracranial aneurysm. So that would be comparable right here, aneurysm coil embolization. And forgive me, I don't know why the image didn't pop over here. I'll fix that also. I'm like 3 for 3 or 4 for 3. I'm striking out. So in this case, DRLs, you guys are roughly, assuming this is gray centimeter squared, 823. And so you're a little bit higher, assuming this is the same aneurysm coil embolization that they're talking about as you. It very well may not be. And so when you compare your DRL at 823 and their average is a little less than 400, you might be comparing apples and oranges. And so it's hard to say. That's the hard thing about comparing. You don't necessarily need to compare DRLs from country to country. You really don't. But we typically do just to give us an idea of kind of where we're at, to gauge a way to say, are we doing okay? You may as a country have a DRL set for a particular procedure, but as you can see, like Switzerland, they may compare to some of their neighbors, such as Germany. There's no reason why probably they should probably lower theirs. Anyway, so here's your neuro stuff. Once again, more numbers. Excuse me, to compare. So now just in general, here's this publication I took the data from. It's a good publication. It's relatively recent. And so it's actually from Korea, Dr. Lee and his group. And they looked at themselves, of course, South Korea. And you can see diagnostic reference levels with their mean, minims, and max. Everything listed here for a variety of different procedures. And I'm just giving you this data so you can look at it as a group. I'm not trying to, like I said, I'm not trying to say these are the right values or the wrong values. Here's Spain, their diagnostic reference levels. And once again, look, this list is different than this list. They didn't do anything with Hickman's, for example. Whereas in Korea, they actually looked at Hickman's, Hickman line placements. Looking at Germany, completely different list. And their diagnostic reference levels and their units of gray centimeters squared. Okay, Thai, this is back to you guys, Thai data. And now we're looking kind of in the cath lab. So you guys looked at CAPS and your air kerma at the reference point. So that's great. Cumulative air kerma. So your diagnostic reference level here at 75 percentile. You guys are doing good. Now let's compare that to Switzerland, if you wanted to. So you got your percutaneous coronary intervention. This is 110. And here you guys are. Whoops, did I get the right one? Let's see where to go. Oh, I'm sorry, I went the wrong direction. Yeah, DAP 110. You guys are 82. Sorry, I was looking at the wrong. 1,000 sounded wrong. So you guys are 82, they're 110. So just as an example, you guys are, you're a little lower. That's great. Here's some Finland, and their DAP is 75, so they're just a hair lower than you guys. So you guys are in the ballpark. That's awesome. You guys are doing great. So Thai DRL values are in the middle of the international data, not too high, not too low. My comment to you is just check. I would recommend, as you noticed, all of the publications, they typically use gray centimeter squared. if you want something that's easily viewable and comparable to everything else in the publication, you may change your units over to gray centimeter squared. So what do you compare? Now, like I said, it doesn't have to be that you're comparing the same thing that internationally everyone else is comparing, but maybe you pick at least one procedure or a couple of procedures. So it's just a way for you as a barometer, as a measure, as a gauge to know how well you are in Thailand compared to maybe your surrounding neighbors, India, Korea, China. You can just kind of look at the local ones, and obviously on the Indochina, how everyone else is doing around you. All right, I'm a couple minutes over, so I'll kind of go through this a little quick. So let's talk about the last thing is alert levels. So diagnostic reference levels allow you as a country to help gauge everyone to make sure as a hospital system in the in your country that you're all basically doing about the same dose. Now, it doesn't necessarily mean that everyone has to be below the diagnostic reference level, but it's a point where everyone can try to get better. Now, what about at your local hospital? Now, how do you know that the procedures you're doing, if they're, how do you know what is an appropriate dose level or not? And so you need to set up quality control process and set up alert levels. So if you're doing a particular procedure, that procedure may have an average dose across all of your patients for all the years that you're doing that procedure. And if a patient pops above, if one patient is above that, you're going to want to go in and kind of ask yourself, why did that patient get more dose than the average or the typical, the expected? It might be that that was a trainee and they just didn't quite know how to do it. So it took them a lot longer. That's fine. That's great. It's an educational, it's a time for us to educate. Or the patient was very difficult, or who knows, patient may have been exceptionally large. And there's just a reason maybe that that dose is higher. And so you want to set alert levels so you can investigate the few cases that do float to the top so that you can keep your doses mostly consistent year to year. It's good for your patients, it's good for you. Now, most hospitals will set their quality control levels at the tissue effect level, 2, 3, maybe 4 gray. Now, I would say that is okay if you're doing interventional procedures. But if you think about the fact that you probably do in a very busy, large academic type hospital, you're probably doing tens of thousands of interventional cath lab procedures a year. Only maybe a couple hundred, a few hundred will exceed this 2, 3, 4 gray range. And so if you set that as your quality control alert level, then you're really not able to check adequately how well as an institution you're doing because you're only doing it for just a very small percentage of your procedures. It's definitely not appropriate to use the tissue effect level, the 2, 3, 4 gray, if you're setting alert levels for kids. We, as in a pediatric centers, rarely even get this high for the more complex interventional and cath procedures, but especially in radiology when you're doing VCUGs, video swallows, enemas, all that kind of stuff, you're never, ever, ever going to get close to 2, 3 gray. I hope you never do. If you do, you did something probably wrong. So we need to set quality control levels that are specific to your hospital and that are reasonable for the procedure. So I'm going to share you how we did it at our hospital. And we created a mathematical model so that you could implement it at your hospital if you were interested. It's something that we're publishing. Hopefully it'll be finished publication real soon. So what we basically did is we went in and we looked at all of our procedures, GI placement, tube placement, VCUGs, et cetera, et cetera. We did it for regular radiology, our tilt tables. We did it for interventional systems in the cath lab, the IR lab. We did it for our mobile CRMs. We just hundreds of thousands of data points, and we did some statistics. So let me share how we built this process and how you could use it if you were interested. So one of the things we wanted to do is we created a simple equation, which you see here. And what this will allow you to do is to take your data and you can convert it to our data, and you can use the all of this statistics that we've calculated. So UA may not have this many patients because you might not be a pediatric hospital. And so you may not have tens of thousands of patients that do VSS or VCUGs. So if you try to do your average on maybe two or 300 patients, the statistics just won't be real good. So we have really good statistics, but this value, this absolute value, the y-axis might not look anything like yours. Your doses might be higher or lower than ours. And so you need to scale your doses. And that's what this equation is. This equation will allow you to scale your doses and our doses so that you can set an alert level that makes sense for your patient dose values. So you'll need to know a patient thickness, on average patient thickness. You don't need to know exactly, just a good ballpark estimate. The M value and this S sub alpha are values that are in some tables and they're coming in the next slides that you'll just look up. And this C value, the C hat, which forgive me, that's a typo. It shouldn't say Z, it should say C hat. That's an intercept value. This is the value that you're going to use to scale your doses so they match ours. So you can use the equation. And what we did is we set up our alert levels at 5% and 1%. So only 5% of all of our procedures, when you look at all the statistics, when you look at all of the doses, that only 5% of them would be over obviously the 5%, and only 1% of the procedures would be above the 1%. So we're not talking about an alert level that'll trigger every day. It'll probably trigger maybe a handful of times a month or a year. And so what you do is you use this equation to come up with to scale your doses so you can use our data. And what you do is you take the average dose from an average sized patient, this X average, and you apply it to this equation. And so for all of the different, C-arms, various different fluoroscopic systems, I have these plots here. They'll give you, if you want the 50th percentile, the 90th percentile, 98th percentile, whatever you want. So the 5%, the 1%, whatever you want for your alert level. And this value right here is going to be somewhat equivalent to your DRL. Not that it is a DRL. And I'll give you an example of how to use this. Now we grouped this, these are C-arms, low, medium, high. It's hard to necessarily say which procedure is quote unquote a low dose procedure versus a medium versus a high. We had to just make a relative guess at that. You would just have to make the same guess. If you consider it a medium dose procedure, you would use these fitting functions in the medium. What makes probably more sense when you're looking at general fluoro, you have like your GIs, your VCUGs, all of this. And then here's our data here. I'm not going through every slide because every slide basically is the same thing, but for just every different machine. So for in the interventional, we have the angio and neuro stuff, abdomen and MSK, and then our really low dose stuff like PICS, line stuff. And here's the data from that. And then cath lab, same thing. We have the diagnostic imaging when we do in the cath lab, and then the low, medium, and high. And here's your quote unquote low, medium, and high procedures and all the fitting functions. All right, so I gave you all of that data. So when you have my actual PDF of my slides, if you wanted to apply this, here is the slide that'll tell you how to do it. So we'll step through this one a little quicker. And then if you need all the data, it's there. So assume an adult facility calculates an average cumulative error curve at the international reference point for a average size patient. Let's say their patient at population is about 25 centimeters AP thickness. And the average output, that error curve value for a GI study, is 20 milligray. All right, so it's a GI procedure. So I'm going to use this data here, and I'm going to use this equation to scale this facility's data to ours. So I know D average, because I looked it up at the facility, is 20 milligray. And M value comes from right here. X average is their average patient thickness, 25 centimeters. So I do the calculations and it comes up with a scaling factor of negative 2.104. Now I want to create an alert level at the 98th upper prediction level. So that means the 1%. Remember, 98th, if you think of a bell curve, you got 1% here, 1% there. So we're thinking 1%. So only 1% of all data would trip at this level or trigger this level. So I have a 2-year-old toddler. So this patient is now only 12 centimeters thick. So if I go over to my equation from the very beginning of the slides, I have the M value, which is here, the X nu, this is my 12 centimeter thick patient, 12, plus S alpha, which comes from right here. S, the alpha is my intervention level, so I want 98%, so I'm using 0.3. If I wanted to do a 5%, I pick 0.5, or 50%, it'd be 0.7. So whichever value, in this case, I'm doing 1%, so 0.3. And then that C hat, remember, this is your data. You know your data for this 25 centimeter thick adult. But what I really want to do is set my alert level for my kids, my pediatric patients. So I take that, it's a negative 2.104 scaling factor. I plug it all in, I do the math, and it comes up with a 6.1 milligray alert level. So for a GI study, only a 1% of the patients will typically pass this level. Now, this assumes that the dose that you would use on this larger patient will scale for this smaller patient, which is this is a typical assumption because your machine changes as long as the auto exposure is the same on the machine from small to big, you would expect it to scale. So now you could do the same thing for a 25 centimeter patient. If you want to set an alert level, you just do the same thing, get the M slope times the patient's thickness, 25. You're doing it for the 1%, 0.3, and then your scaling factor you already calculated. So the alert level now for a 25 centimeter person getting a GI would be 87 milligram. So you can see how the alert levels for non-interventional are going to be a lot lower. That said, that doesn't necessarily mean we're going to be checking every one of our exams. These values represent the upper level of what you typically do at your hospital. So a quick summary, the skills of the fluoroscopist, the interventionalist, they're the ones that typically affect the patient dose, so the usage of the machine. So we want to initially set up the protocol, the parameters, so that when the interventionalist, the fluoroscopist walks in, they'll use the system and they'll be comfortable using it. And we know it's properly set up to get the right dose, pulse, the right dose to the detector, all of that. We want to teach everyone to make sure they use proper geometry and setup. We want the largest source to the patient distance. In other words, keep the table and the patient as far away from the source as possible. Small patient to image distance, so keep the detector as close to the patient as possible. We're going to do our best on a rotating system to minimize the oblique and lateral angles. Longer path lengths through the patient obviously increases the dose. We want to do our best to collimate as much as possible. And this has a lot to do with what we talked about last week, that virtual collimation. And also just means we're reducing the area of the patient dose. So it reduces the overall risk. We're going to use pulsed as much as we can and use the lowest pulsed as much as possible. We're going to do the least amount of imaging with fluoro as we can. So keep our foot off the pedal. Use as much as we can the last fluoro hold and last fluoro loop. And do our best to limit the number of DSAs and CINE runs because those are really high dose procedures. Not procedures, techniques. And then of course we just watch. We have the cumulative air kerma at the reference point displayed on the monitor. So as we kind of talked about in our last Q&A, you just keep an eye on that to make sure the doses aren't creeping up too high. Training is very important. So we typically, at least at our hospital, I don't know how you do it, but this is just a recommendation. We always do onboarding for all of our new technologists. We make sure they're trained on the technology at the hospital. So they know how to do fluoroscopy. That's why they went to school. But they may not have used a Siemens or a GE or a Canon machine. So they just need to be trained. So they go through a training, an in-person, hands-on training, and then they do an online PowerPoint that's just on the web at our institution. Another thing that is something that we do here in the US, I'm not certain if it's required in Thailand, but there's credentialing. So any physician that wants to be the one that pushes the pedal, they're the one that actually does the beam on to the patient. They have to be credentialed to know how to operate a fluoroscopy system. This requires hands-on training. They have to do a 1 2 hour, they have to do a one class for at least an hour where they go in, they're taught all the buttons and how to reduce and dose and all the stuff we've talked about. And then annually they have to do an online module. Now, if they're not credentialed, that's fine. They can still be in the room. They can still tell the technologist how to, beam on, beam off, move this, do that. The technologist does just runs the machine. So we talked about diagnostic reference levels, and we talked about the need to set up quality control and alert levels. Those are independent of each other. I think they're both very important. And the DRLs will act as that upper threshold and a goal for all hospitals to meet. And the quality control will allow you as a hospital, as a group of radiologists and physicists and technologists to constantly make sure patient to patient, day to day, your systems are always safe and consistent. All right. Once again, I apologize. I went a little over on that. So we'll see how many questions we have now.
Thank you so much, Sam. One thing that I noticed from your lecture is you like a lot of number and formulas and mathematics.
I did that for you, Tanya. I knew you liked
Thank
physics,
you.
math too.
Thank you so much. So there were two questions from the last session that carry on to this
Okay.
one. I forgot to ask. I think it is about the thing that we talked earlier on the actual on the screen that show the DAP or ACURMA compared to the actual calculations. So the first question is for some neurointerventionists, some neuro IR procedure that need to do the cone beam CT or 3D DSA, is it okay to use the dose report from the machine?
The dose
And
the dose
the dose,
report at
oh
the
yeah,
end.
at the end.
Mhm.
So that may be the same thing that we talked
Yeah.
earlier about the dose and the actual calculations from the physicist.
Yeah, that's a good that'll get you close. So it'll tell you the total value. So if you're doing spins, if you're doing fluoro, you're doing DSA, you're doing a lot of complex stuff.
Mm-hmm.
The cumulative air kerma is going to always that will collect the entire time. It's the fluoro time that might not be the same. And that's why fluoro time is usually not the metric you really want to look at.
Mm-hmm.
So cumulative air kerma will be a total number for everything you do in that procedure. And that, let's say it's 5,000. And that's the
Mm-hmm.
value at the end of the procedure. You look at and go, oh, 5,000. You would say, hey, call it the physicist. Let's do a dose calculation. Let's just make sure everything's okay. And so they would come in, the physicist would get the patient data. They'd probably say, hey, how tall was the table? Or how tall are you? One of the two. And then they could be able to go back. They would take that dose report and go do the calculations. So yes, it's okay. That dose report at the end is actually very important. I would highly recommend, you always archive it. It should be collected. If you have a policy where you send some information to your PACs for reading and diagnostic, I would always at least archive the dose report. That's just a good way to, in case a couple weeks later you go back and you say, hey, let's do a dose calculation. The interventional machines themselves, when you do long, big, complex procedures, the hard drive just fills up, and so that's why you don't go see hundreds of patients on those machines. Usually you'll maybe see, I don't know, 20, 30, 40 patients on it, and then they start falling off the machine. They start getting deleted. So it's really good to auto archive those dose reports, usually to PACS or someplace.
Yeah. So does it mean like we don't need to do the calculations in every patient
No.
unless the number go high above our like the standard number or something that we set it up. So that's why we need to contact the medical physicist to do some calculation and get the actual dose, right?
Yeah. Yeah. And that threshold is something that you as a hospital need to establish. As an example, at our hospital, we chose 5,000. So
Mm-hmm.
5,000 milligray. And that's something that me as a physicist, we have a safety officer, a radiation safety officer. And then we had our manager of IR, the physician, and the manager of the cath lab. And so we had a group come together and we just looked at the data. We said, oh, we've had in the last year, we've had, I don't know, let's say 10 patients with over 3,000 milligray and none of them had any skin reaction. And we had one or two patients at 5,000. They still didn't have skin reaction, but that's a good safe place to put a threshold. So that's why we chose that. You as a hospital may choose lower. I mean, it's really, I would just recommend you look at your data. And if you're not collecting this data, start doing it now. And you'll start to see, just as you log in, how many patients will surpass a certain level. I know as Thailand right now, they're starting to distribute the radiation dose monitoring software. That's great because the dose monitoring software will help you do this because then you can just
Mm-hmm.
run reports really quick and easy.
Yeah. So the follow-up question is about how to record the radiation dose in case that the study that we do the cone beam CT or 3D DSA. So should we use the summation dose report from the machine or do we need to do the calculation separately by the physicist? So the answer is it like going to be the same answer, like depend on the threshold?
Yeah, it really depends on the threshold. So if your cumulative air kerma value exceeds your threshold, then you look at all of the data together. You'll look at your fluoros, your DSAs, your spins, you look at all that and you do your calculations from that. If I if you don't get to that threshold, even though you did a lot of spins,
Mm-hmm.
even if you don't get to that threshold, I wouldn't worry too much. So if you think about the spins you just bring that up as an example. The nice thing about the spin is it actually is distributing the dose all the way around the patient. So when you
Mm-hmm.
consider the skin, the spins actually don't put a lot of dose on the skin because it spins it around you. It
Mm-hmm.
averages it out. The areas that you can get into a lot of trouble are doing a lot of cine runs or DSAs, obviously, because you acquire the image for the mask, and then you acquire the image when you inject the contrast in it to do the subtraction, and these tend to be pretty high, a little bit higher dose values, and so you're basically acquiring two images to do one thing, and they're a little bit higher dose so that the noise is lower, and so those
Mm-hmm.
can be kind of high dose. But like I said, if you're not crossing that threshold, I wouldn't worry about doing the skin dose calculations.
I see. I see. So on one slide that you do the comparison between the Thai data compared with the benchmark from the other country, and you mentioned about that we need to check on our unit. It's like a milligray
Mhm.
or gray per
Yep.
cm square. So I was wondering because I believe that we got that number from the screenshot,
Mhm.
not the physicist that calculate that thing. So I was wondering that like what do we have in the screenshot? Should it be the same as the benchmark to show that because
It,
I don't think we can do like the some conversion of formulas to convert those numbers that gonna cause more issue for us.
yeah, and so let's see. Do I have? Okay. Oh, sorry. Let me pop off here. Oh, actually, I think it's in my previous talk. Let me pull my
Yeah,
other talk
that
up.
we have
So
like
my
a
the so for example, my machines, the units
Mhm.
are in milligray centimeter squares. So,
Okay.
but let me show you my dose report as soon as it pops up. The value was much higher than your value. You
Mm-hmm.
can Let's see.
เอ๊ะ
Here we
ทาง
go.
ทางทางทีมที่ทำอยู่ที่ช่วยเก็บข้อมูลของทางอินเตอร์เวนนะคะมีคอมเมนต์ไหมเอ่ยว่าเราใช้เราเก็บหน่วยถูกต้องไหมหรือว่าอะไรไหมคะเดี๋ยวจะเปิดไมค์ให้อะค่ะยกมือก็ได้
Can you see my screen? Is it still presenting?
Yes we can see your
Okay.
screen
So you can see here um, my cumulative cap or DAP, milligray centimeter squared, is 22,000. So that would be, if you, obviously if you move the decimal over 3 for gray, that would be 22.7 gray centimeter squared. And so your numbers were just, let me, nope, this one right here. There we go. Milligray centimeter squared, your numbers, see, they're not, I would expect that to be 24,200 or something.
I see what
if
you're
that was
saying.
milligray. Yeah.
Okay. And on like the benchmark things, they use gray. So
They
which means
use, yeah,
they
they
use gray
use
per centimeter
gray
square.
centimeter. Mhm.
Yeah. But
You
I
could be
don't.
right. I mean, I would just say go back and double check.
Okay.
And you do not need to. You don't have to compare them if you don't want to. But as I did really simple here, I mean, if you got all of your data was in milligray centimeter squared, and so your numbers were 22,700 or whatever, that would say that's your average. Well, if you wanted to, you could simply to change it to gray, you just obviously do a little bit of math, and you could make that 22.7 gray centimeter squared.
I see. Yeah. So the next question is about the cone beam CT for the dental cone beam CT. Do we also check the dose reading?
You'll never get high enough on a dental.
Okay.
You can. The dental cone beam will still have the same air kerma and cap or DAP. It will, but by way of effect, tissue effect, not an issue. And by way of like organ dose, really the biggest one that you're considering is your thyroid, from the scatter down to the thyroid. And thyroids are sensitive, but they're not the most sensitive organ. And so risk and tissue effects, those two separate things, are not really big, and especially in dental. So I would track it. And if you want, I would do a diagnostic reference level. I think it's important so that everyone, because dental is the one thing, maybe interoral, which is more is more uniform. Dental is something everyone gets exposed to, right? Typically once a year, once a couple of years, they're going to go in and they're going to get at least 4 images of their face. And so they're really low dose. They're really low. We're talking 10, maybe, or I think it's maybe 10, 15 microsievert. I mean, it's equivalent to a background radiation dose per day. So it's really low. But if you're getting it every year of your entire life, then you want to make sure the dose is good. You don't want to be overdosing every patient in dental. So though the doses are low in dental, you still want to get diagnostic reference levels to make sure everyone in Thailand is, doing great, doing good.
I see. Yeah. So next question is about can you explain more about the useful necessity of those structural report, which we'll use for PSD calculation?
The structure, the dose structure report. So in this case, so there's 2 reports that are presented at the end of every procedure. There is the dose capture, the dose screen. This is physically a DICOM image. And this is good because you can visually see everything here, and you can take it and do all your dose calculations. And then there is a structured dose report that actually you don't physically see, but when you have your dose reporting software, that's the thing that you'll send your structured dose report to your software. And there is a lot of information. So if you're comfortable looking at the DICOM information, so you go in, you open up the image, and you look at the DICOM information, it will tell you everything. It'll usually tell you angles, it'll tell you dosing, it'll tell you dose per angle. If you've ever looked at a structured dose report, a DICOM report for a fluoro, it is hundreds of pages long. because every time you step on the pedal, it creates something like 2 pages worth of data. And so it's something that you probably as a physicist or a technologist would not want to look at because it's hundreds of pages of data. But if you have a software out like Randometrics or the software that you plan to do for your dose tracking, it will collect that and it'll find all the information that's important, and it will store it in their server so that you can run reports really easy. So when you get that software, you want to send this report that you see on my screen. This
Mm-hmm.
report, the dose report, goes to PACS. That's something that I would highly recommend you guys archive that in some place like PACS or wherever you are. And then the structured dose report would go to your dose reporting software.
I thought that we should send those like the last page of the dose report to our archive in every patient because we put the radiation dose to the patient. That is like a must to do.
Yeah. Yeah.
Right.
And and as a radiologist, oftentimes, or an interventionalist, they're going to put that in their report, but it won't be as complete. They might say the cumulative dose and the patient
Mm-hmm.
got blah 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 milligray. But having this part of that study on PACS, we can always go back and whenever we want. And then you can look at all of these 15 or so different runs. And anyway,
Yes.
I highly recommend you make sure it's archived.
Yes. Sure. So next question is about the dose metrics. Do you recommend to setting up the DRL or QC alert level? There should be CAK or DAP or flow time or only the DAP alone or ACRMA alone is enough. So if the multiple metrics are required in the clinical practice, how we prioritize which one is the most important?
Yeah, it's a long list, isn't it? There's a lot to do here.
Yes.
So for diagnostic reference levels, I would recommend, as you actually have already done in Thailand, you guys have already started to collect. In this case, in this example right here, this is CAP or DAP
Mm-hmm.
for your interventional and your neuro, and then for your cath information, you did both CAP and DAP, and the cumulative error karma. So for diagnostic reference levels, I'd recommend actually doing those two things: CAP and error karma. I think those are very important. They're two different numbers that can be used two different ways, as you may recall. CAP, when you apply the correction value, can give you an estimate of risk, stochastic cancer effect. Since the error karma, when you do that equation that we talked about, that will tell you the skin dose. And so that'll tell you the likelihood of an effect. So they're two different things. So now the next question was, what about what should you do on your quality control? So diagnostic reference levels, that's at the national level, right? Everyone's going to send that off. You guys in Thailand's going to collect all that data. Dr. Panrutai and her group's going to process it, and then they're going to send out these numbers like you see here. And then as a hospital, you're going to try, do your best to maybe get below that. But for quality control, you're going to look at every one of your studies done every day of the year. And some of them, like you saw, in my examples, when you look at my patients, so let's look over here, we'll just zoom up, VCUG. So the vast majority of my patients are under this green line is the 5% and the blue line is the 1%. The vast majority, so 99% of all of our patients are below this. This is actually, I think, 2.5 years worth of data. So in 2.5 years, we had 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, let's say maybe 15 or 20 patients. So not that much. But for us, this is something that's important to track because we want to know why those values, why did this patient right here, a teeny little kid, why did he get, or she, why did they get probably 10 times the radiation dose as all the other kids? There's no reason for that. And so that's why we set up these alert levels. These alert levels are established using error karma. We only look at error karma for alert levels. And why is that? It's I don't want to do all this tracking for two numbers. It's just I eat both. An alert system is only there for you just to go investigate, and so you only need one value. So pick one of the two. I personally pick air kerma, and air kerma is important to me because that tells me something about risk now. Now is something that I have to worry about. If someone gets a skin burn, they lose their hair, if they have necrosis, ulceration, I need to worry about that now. Cancer is something we need to worry about, but that's just something that it's so hard to predict in the long term. And so CAP is for me not that important of a measurement, but that's my personal thing. CAP is just it's harder to use when I need to make a decision today about lowering the dose or raising the dose to a protocol as a physicist. So the answer is diagnostic reference levels. Yes, collect both the CAP and the KERMA, air KERMA. For alert levels, I would just do the air KERMA, and that's what I would prioritize.
That's good to me. Yeah. เอ๊ะทางพัชรีหรือว่าทางฟิสิกส์ที่จุฬามีคอมเมนต์ไหมคะที่ช่วยกันเก็บโดสของ IR นะคะอาจารย์เพชรรีอยู่ไหนเอ่ยเปิดได้ไหมเดี๋ยวนะหรือว่าหนูน้องตูนหทัยพัฒน์มีคอมเมนต์ไหมเอ่ยเรื่องของไอ้ตอนที่ช่วยเก็บโดสนะคะหรือว่าอาจารย์อาร์ตนิวโร IR มีคอมเมนต์ไหมครับเดี๋ยวเปิดไมค์ให้ Well, there is one comment. It's the same comments that maybe we need to check on the units when we correct those things, and maybe that is the one thing that we should reiterate to our group when we do like a manual collections. But that issue should be resolved when we have like a those measurement software and it's like a directly send all information.
Yeah. And that's I mean you kind of said it. It's that's the hardest part about doing all the manual collection. At first, it's the most important part to start the process, and you guys have been doing that. But obviously, units, especially CAP. One machine will say milligray centimeter squared. Another will say gray centimeter squared. Another one will say milligray meter squared. I've worked over my career with probably 4 or 5 different vendors, and they've all had different units. It drives me crazy. So yeah, so even when all this stuff goes up to your software, hopefully the software, you'll still need to double check this. You'll want to kind of spot check it, but you want to make sure that all the software is getting all of the units correct too.
So does it mean like each vendor have a different unit?
Generally, yes. Yes.
Same or different? Different.
Yes. Yeah. So if you work in a hospital and you have a Siemens unit and a GE unit and a Canon, and you just go down the hallway, you may find that the CAP value is different in every room.
Oh, okay. So does it mean that the software company things should help us when we send those data? They should rearrange to get the same unit.
Yes. So if you look at Ratometrics, all of those vendors put the information into Ratometrics, but Ratometrics has only one unit. So yes, it's a little simpler that way.
Same comments about the unit. So that is one thing that I just know, because initially I thought that we have like each machine has the same unit. Maybe like some manual things that we get wrong, but okay.
Yeah, no, it drives you crazy too. And that's why air kerma is actually good, because it's one unit. It's milligray. Whereas cap is just different. It just depends on how some people do it. Some vendors do it a little differently.
I see. So thank you so much, Sam, for helping us and give us a feedback on what we have done so far in terms of DRL in the Fluoro and also IR, and also giving a lectures for today.
Yeah,
Yeah.
no. Yeah, I'll make you a deal. Eh, I'll come to Thailand and I'll check your units for you. Then we can
Yes.
go get some good Thai food.
Sure. So after the COVID thing is better, for sure, for sure.
Yeah. No, I
Yeah.
appreciate it. So if there's additional
Yes.
questions, like I said, because some people
Mhm.
might not have been able to watch today's lecture because they're busy,
Yes.
we can always talk about this next week if we need to.
Yes. and สำหรับท่านที่ดูนะคะไอ้ตัวเอกสารนะคะจะให้อยู่ในลิงก์ที่ท่านใช้ลงทะเบียนนะคะสามารถเข้าไปดาวน์โหลดเอกสารประกอบการประชุมได้ในแต่ละครั้งนะคะแล้วก็หลังจากที่เสร็จเลคเชอร์วันนี้แล้วจะมีลิงก์ส่งไปให้ทำการประเมินนะคะช่วยทำการประเมินแล้วก็ส่งกลับคืนมาภายในวันพฤหัสตอนเที่ยงคืนนะคะเพื่อที่วันศุกร์ตอนเช้าจะได้รับ CME เครดิตนะคะแล้วก็ใบเซอร์ติฟิเคตแล้วก็วันศุกร์ก็จะได้รับลิงก์ของอาทิตย์ถัดไปด้วยนะคะ for the audience who register, you can check on your email or log in to the IAOC website to download the PDF lectures. And you will get a link for evaluation. Please do the evaluation and send it back by Thursday midnight. So Friday, you will get the certificate and also CME credit. And you will get the link for the next week on Friday.